So good morning, everyone. Thank you so much for having me here today. So today I will be talking about some tips and tricks of advanced imaging in orthopedic trauma. So the talk today will be broken up into some clinical tips and tricks and also some logistical tips and tricks to help with image optimization. So starting off with some clinical tips and tricks, we often think of secondary signs in the setting of radiographs to suggest soft tissue injury. So for example, a Sagan fracture or a deep sulcus sign on a knee radiograph may suggest an anterior cruciate ligament tear. However, we can also think of secondary signs in the setting of advanced imaging to help identify injuries. So first, we'll go over utilizing secondary signs in the setting of advanced imaging to help to confirm occult fractures. So for example, we can utilize the principle that marrow fat will extend from the intramedullary canal at the site of a fracture to extend into the adjacent soft tissues. So lipohemarthrosis is a finding where we see layering fat, fluid, and blood products within a joint, and that is consistent with an intra-articular fracture. So here on these images in soft tissue window, you can see layering non-dependent fat, which is dark, intermediate density fluid in the middle, and hyperdense blood products layering dependently within the knee joint. And this is consistent with an intra-articular fracture. And indeed, on bone windows, here you can see that there is a non-displaced lateral tibial plateau fracture. Similarly, lipohemobursa is layering blood and fat within a bursa consistent with an adjacent fracture. In this example on soft tissue windows, we can see layering blood and fat within the deep infrapatellar bursa. And although we looked very closely for an adjacent fracture, we were unable to identify this on CT. So this prompted an MRI. And this MRI was positive for a non-displaced extra-articular proximal tibial fracture. Here on these T1 weighted images on MRI, you can see T1 dark or hypointense fracture lines at the proximal tibia, and adjacent you can see layering fat and blood products within the deep infrapatellar bursa. Here in this same case on fluid-sensitive sequences, you can see marrow edema in the region of the fracture, and again you can see layering fat and blood products within the deep infrapatellar bursa. Similarly, in the setting of a distal radius fracture, although not a very common finding, sometimes one can see layering fat and blood within the adjacent extensor compartments. And so here on these soft tissue windows, you can see that there is layering fat and blood within the second extensor compartment. And on bone windows, you can see that there is a non-displaced distal radius fracture. Similar to utilizing secondary signs on advanced imaging to help to confirm occult fractures, we can also utilize secondary signs on advanced imaging to help to identify and confirm soft tissue injuries. For example, we can utilize the position of adjacent soft tissue structures. So for example, we can utilize the position of a biceps tendon to help to confirm the presence of a subscapularis tear. So here on the image on the left, you can see that in the setting of an intact subscapularis tendon, the biceps tendon is appropriately positioned. And here on the right, you can see that in the setting of a subscapularis tendon tear, the biceps tendon is medially subluxed into the substance of the subscapularis. Here in another example, we can utilize the position of the biceps tendon again to help confirm the presence of a full thickness pectoralis major tear. On the left, on these images, you can see that in the presence of an intact pectoralis major, that the biceps tendon is appropriately positioned closely opposed to the underlying humerus. On the image on the right, you can see in the setting of a full thickness pectoralis major tear that there is anterior uplifting of the biceps tendon. We utilize specific sequences in musculoskeletal MRI. And for a quick evaluation of MRI in the setting of trauma, there are two main sequences that you may wish to look at. So the first, as shown on the left, is a T1 weighted image where the marrow fat and the adjacent soft tissue fat will be bright, and the muscle is of intermediate signal intensity. And we utilize the T1 weighted sequences, especially to evaluate for marrow signal in infiltrative processes, and also in the setting of trauma to evaluate for T1 hypointense or dark fracture lines, as you can see here at the greater tuberosity. The other main sequence that you may wish to look at are fluid-sensitive sequences, such as T2 fat-saturated or STIR sequences, as you can see here on the right. So here you can see that the fat has been suppressed out and edema and fluid is bright. And so you can see marrow edema here in the region of the fracture at the greater tuberosity. And sometimes the T2 fat-saturated or fluid-sensitive signal will be more pronounced as compared to the signal on the T1 weighted images and can help to direct your attention to the appropriate area of concern. Speaking of evaluation of marrow on MRI, differentiating between pathologic fractures and benign fractures can sometimes be difficult, particularly in the setting of an acute injury, as you will have a lot of adjacent inflammatory and edematous changes. There are some imaging features that can help to differentiate between pathologic and benign fractures. So here on the image on the left, you can see a benign stress fracture with a T1 hypointense line at the medial aspect of the femoral neck, consistent with a benign stress fracture. And you have adjacent heterogeneous T1 signal with interspersed areas of marrow fat and with a gradual transition to normal marrow. On the right, you can see a pathologic fracture with subtle cortical disruption of the posterior humeral cortex, and underlying this, you can see a markedly T1 hypointense pathologic lesion with convex margins without areas of interspersed fat and with a sharp transition to the adjacent marrow. And finally, we will now end on a few logistical tips and tricks and general imaging planning that will be helpful in optimizing the images you obtain. So we will begin with CT. So in CT imaging, automatic reconstructions in the sagittal and coronal planes are often performed in the plane of the scanner or in the plane of the body. And depending on how the patient is positioned within the scanner, the lower extremities are often externally rotated, the upper extremities may be placed on the body or in any number of different positions, and the automatic reconstructions will therefore not be orthogonal to the extremity or the area of concern. So for example, on the left here, you can see that the automatic sagittal reconstructions are not in the actual sagittal plane with respect to the calf, and so the subsequent sagittal reconstructions are off plane. On the images on the right, you can see that these are reformats that we have generated on the reading workstation in the actual sagittal plane with respect to the calf, and the sagittal images are much more on plane, and this can be helpful in confirmation of the degree and direction of displacement and dislocation, as well as for confirmation of subtle osseous findings in multiple planes. Oftentimes, we will need to utilize advanced imaging in the setting of hardware, but as I am sure all of you are aware, metal hardware often results in significant artifact which can preclude evaluation of the adjacent structures. So here in images on the left, you can see that the patient has bilateral total hip arthroplasty hardware in place, which results in significant streak artifact precluding evaluation of the adjacent structures, which sometimes are the area of concern. And here on the image on the right, you can see that in CT, we can utilize metal artifact reduction algorithms, which can help to decrease the streak artifact from the metal hardware and can help to allow you to evaluate the adjacent structures. Moving on to MR optimization, because of the orientation of the muscle, joints, and extremities, advanced orthopedic imaging requires particular sequences, protocols, and planes, and it is important to make sure that the imaging studies are appropriately tailored to the area of clinical concern and the clinical question. So for example, the images on the right demonstrate planes of imaging and field of view for pectoralis major imaging. So if the clinical concern is the pectoralis major, we will often place the patient prone or utilize a saturation band to decrease respiratory artifact. And we can also use larger field of views to ensure imaging of the entirety of the pectoralis major. In addition, we can tailor the examination and utilize smaller field of view images to evaluate for the humeral attachment of the pectoralis major, which is often the area of concern. This is in contrast to a standard shoulder MRI with images seen here on the left, which is a much smaller field of view, and the planes are orthogonal to the glenohumeral joint and are tailored to evaluate for internal derangement of the shoulder. Again, sometimes we will need to perform MRI in the setting of metal hardware, which can result in significant artifact. Similar to CT, we can utilize metal artifact reduction principles to decrease metal artifact. So some of these include utilizing a lower strength magnet, so for example, a 1.5 Tesla magnet as opposed to a 3 Tesla magnet, as you can see here on images on the left, which markedly decrease artifact. In addition, we can utilize increased bandwidth of the radiofrequency pulses used to decrease artifact, as you can see on the top right image. And we can also use alternative methods of fat suppression for more homogeneous fat suppression, as seen on the image on the bottom right. Thank you all for listening.